Okay, great. Well, Assalamu alaikum. Thank you everyone for taking your time and joining the webinar. And we are really excited to hear from a pioneer of hematology and oncology in Pakistan. So I have actually his profile. So let me quickly go through that and do the introduction. So Dr. Parvez Ahmed is a pioneer in the clinical hematology and bone marrow transplant in Pakistan. He has worked as a hematologist and bone marrow transplant physician at the Armed Forces Bone Marrow Transplant Facility in Pakistan. That is the largest bone marrow transplant facility, which was established initially in 2001. And later he served there as a medical director from 2009 to 2016. He was the medical director of Armed Forces Institute of Pathology till 2017. And after his retirement, he chose to work again and continue to lead the way and establish a new BMT facility at the Quaid-e-Azam International Hospital in Islamabad. And that's not where he stopped. He actually is instrumental in establishing 3 additional BMT facilities in Pakistan, namely Centers for Hematology and Bone Marrow Transplant at Gambit Institute of Medical Sciences in Sindh, PATHWEL Center for Hematology and BMT at Thalassemia Center in Rawalpindi, and a BMT center at Pakistan Kidney and Liver Institute in Lahore. He's the founding president and patron chief of Pakistan Blood and Marrow Transplant Group. And Dr. Ahmed serves as a dean of the Committee of Clinical Hematology at the College of Physicians and Surgeons in Pakistan. And we're really excited to hear from him. He's going to bring a unique local perspective regarding the diagnosis and non-transplant management of aplastic anemia. And our next session in 2 weeks will be again on aplastic anemia, but we will hear the transplant management of aplastic anemia. So Dr. Parvez, please go ahead. Thank you.
Thank you, Faz, for the generous introduction. I have been associated with the aplastic anemia over the last almost 3 decades now, and most of my presentation will be oriented towards the practical aspects based on my experience, though there will be some textbook material as well. So let's start with the case. This is a 16-year-old male adolescent from Afghanistan who presented in our OPD in March 2025 with history of frequent mucosal bleeds. He was diagnosed and managed as a case of chronic ITP since 2022 and had received all sort of immunosuppressives and altumopag. Bone marrow done in Afghanistan in 2022 and repeated at another facility in March 2025 was consistent with peripheral destruction of platelets. He was referred for opinion regarding splenectomy as the only option left for his chronic refractory ITP. There was nothing significant in the family history. His physical examination was unremarkable. So how should we proceed from here? I'll tell my perspective. We can discuss at the end of the presentation if there are any other opinions. I told the family that this is unlikely to be a case of chronic ITP, and what I would like to do is the review of his biopsy and aspiration slides. So the only slides available were of 2025, and the marrow was moderately cellular for his age, with presence of small hypocellular areas. These were subtle areas, and there were islands of erythroid hyperplasia and increased megakaryocytes. Now, these are the findings that we usually see in evolving aplastic anemia as well as in inherited bone marrow failure syndrome. So that's the significance of these findings. So we went for the NGS of this child, and we had one heterozygous and another homozygous mutations. Both were labeled as of undetermined or uncertain significance. But based on the history, We were of the strong opinion that the child has inherited bone marrow failure syndrome, and we proceeded for investigations of Fanconi anemia in this child. So coming to the definition of aplastic anemia, it's basically a misnomer since it's not the anemia, it's the pancytopenia associated with hypocellular bone marrow in the absence of any infiltrate or abnormal finding or fibrosis. Now, initially, marrow can have patchy cellularity, and there can be islands of erythroid hyperplasia with minimal dysrhythmophysis. Now, this is the catch. You can see moderate megaloblastic changes with minimal dysrhythmophysis and erythroid hyperplasia, and people have been misdiagnosed as patients of megaloblastic anemia with these findings. But they are usually seen in evolving aplasia. Most cases are associated with autoimmune attack on hematopoietic stem cells. The trigger is often unidentified. We definitely know it is immune aplastic anemia or idiopathic aplastic anemia, and it should be distinguished from other causes of bone marrow hypoplasia that I'll not go into the detail. Now, incidence is there are differences in the incidence of this disease. There are 2 cases per million population in the Western population and the North American people, but it is 4 to 5 times high in Asian countries and including Pakistan. The increased incidence may be related to the combination of environmental factors such as increased exposure to toxic chemicals, but there may be certain underlying subtle genetic factors. There are 2 peaks. One is during first 3 decades and second is seen after 60 years of age. Now, why aplastic anemia is more common in Asia? And these are the plausible explanations. People have worked on it. Then that there is exposure to drugs and toxins. Then there can be associated hepatitis-associated aplasia. Then there can be inherited bone marrow failure syndromes. Then there is association with certain HLA types. Then there can be aberrant cytokine expression, polymorphism, causing reduced metabolism of the toxins, and aberrant apoptosis. Now, these are the plausible explanations, and we have done some work on these factors in our population. Now, this is the population pyramid of Pakistan. If we compare it with the typical any developed country like UK, we see half of our population is below 30 years of age. And this is in sharp contrast to the UK. And the differences in the disease demographic that we see here, it may be related to the predominant younger population in our people. It may not be the actual pathological differences. Now, this is the epidemiological study that we have done in 1,324 patients of aplastic anemia here. And what we related it with rural residents, low socioeconomic status, and exposure to certain chemicals like pesticides. It was more among our population, but we do not have the significant, the epidemiological differences with the other people. In 2017, we got data from all the tertiary care centers of the country, and we came out that 651 new cases of aplastic were diagnosed. But our estimate was that only 40% of our people, they have access to the tertiary care centers. And based on these figures, we can safely conclude that the total cases per year are close to 2,000 in our population. Majority are younger, have severe and very severe disease. But again, maybe that the patient who are very sick and have more severe aplasia, they are brought to the tertiary care centers. We actually do not have answers to these questions. The largest center is the Armed Forces Bone Marrow Transplant Center. They have got more than 2,500 cases registered with them, and around 130 to 150 new cases are seen every year in this transplant center. The criteria for the diagnosis is standard, that cytopenia, at least two of the following, that hemoglobin less than 5, ANC less than 1.5, and platelet less than 50, plus bone marrow with less than 25 cellularity. And there is no important thing is that there should not be abnormal infiltrate or abnormal bone marrow reticular fibrosis. The severity classification is based on the historical Kemita criteria, and these for patients who have got the severe aplastic anemia, they should have two of the three, that is bone marrow cellularity of less than 25%, ANC of less than 0.5, or platelet less than 20,000. The reticulocyte corrected count less than 1%, or absolute is less than 60,000, but some people would say the absolute reticulocyte count should be less than 30 instead of 60. If the ANC is less than 0.2, we label it as a VSAA. Now, glutathione S transferase enzyme is a detoxifying enzyme, and in patients, 137 aplastic anemia patients and 220 controls, what we found was that GSTM M1 haplotype was polymorphism was more in aplasia compared with the controls. The figures were close to 50% versus 30%. So this may be associated with the increased prevalence of aplastic anemia here. Then this is a small study on 61 aplastic anemia patients that found significant association of HLA-DRB 115 haplotype among aplastic anemia patients. At the same time, DRB 103 had a protective role. It was more often seen among the control population. Now, single nucleotide polymorphism for the FAS or FAS ligand enzyme, apoptotic enzyme, showed that in 392 Pakistani subjects, the FAS ligand was more among the controls, whereas FAS null genotype was more among the aplasia patients. Similarly, this is a profile of 2014 aplastic anemia patients compared with the controls, and it found that there was significant higher level of GCSF and thrombopoietin among the patients with the aplastic anemia. The other cytokine did not reveal any significant association with aplasia. Now, the similar cohort, we did the detailed genotype, and we discovered 10 mutations among our idiopathic aplastic anemia patients. And two of these, those labeled in italics, they were the novel mutations, not earlier reported. These are the label in italics. One is, I'm not sure whether you can see that. One is this one, TERT gene, and another TERT gene. These are two TERT novel mutations that were not previously reported in aplastic anemia patients. Now, pathogenesis revolve around the CTL, cytotoxic T lymphocytes, as well as certain association with the cytokine, genetic factors, and autoantibodies. But surely we do know that it is the cytotoxic T lymphocyte mediated damage to the hematopoietic stem cells. Now, these cytotoxic T lymphocytes, in association with class 1 lymphocyte, they recognize not yet identifiable the antigen over the hematopoietic stem cell that leads to destruction through a direct damage as well as through the activation of the interferon gamma and TNF cytokine. Now, these cytokine can lead to the bone marrow suppression in addition to the direct toxic damage by the CTLs. And ultimately, there is selection of those hematopoietic cells that can evade the immunity. Now, these are the major advances in the aplastic anemia pathophysiology. Immune pathogenesis was reported by the Neil Young, and then Neil Young as well as Ghulam Mufti, they identified certain somatic mutations in aplastic anemia, and clonal hematopoiesis was reported by Shishi Ogawa in 2016. These were the landmarks in the pathogenesis of aplastic anemia. Now, this is another case of 58-year-old woman who is a known diabetes mellitus with a history of aplastic anemia that was diagnosed 5 years ago and responded to the immunosuppressive therapy with ATG and cyclosporin. She presented with increasing fatigue and intermittent low-grade fever. On examination, she appeared pale and had mild hepatosplenomegaly. She had raised creatinine and was labeled as a case of chronic kidney disease and anemia of chronic kidney disease. She was treated with the erythropoietin and was referred for our opinion. And based on the previous history of the aplasia, we thought of some clonal evolution and we went for the repeat bone marrow aspiration as well as the cytogenetics, and the cytogenetic revealed monosomy 7, and the patient was diagnosed as MDS evolving from aplastic anemia. A significant association is seen with PNH and as well as MDS and AML, since aplastic anemia is a clonal disorder. Now, this is quite confusing. There are certain overlapping disorders: aplastic anemia, certain inherited bone marrow failure syndromes, PNH, hypoplastic MDS, and hypoplastic AML. There are certain cases that overlap, and it is difficult to precisely define whether this is a patient that is of hypoplastic MDS, and most of these disorders, they have been transformed from one disorder into another. It can start from the inherited bone marrow failure syndrome or idiopathic aplastic anemia. Around 10 to 15% of the patients of aplastic anemia, they have got some sort of genetic mutations. The common one are the PIG A mutation, BCOR, BCOR-L1, DNMT3 or ASXL1 mutations. AXL, ASXL1 and DMT3 are unfavorable and are likely to be associated with the MDS and ultimately into AML, whereas the PIG-A, B-core or B-core-L, they are of good risk mutations. MDS mutations are seen in up to 5 to 15% of patients. Common, I have already mentioned, but DNMT3A is not seen in pediatric patients. Most common cytogenetic abnormality in the idiopathic acquired aplastic anemia is acquired 6P uniparental zygosity. That is seen in 10 to 15% of patients. And the cytogenetic finding associated with evolution to AML or MDS are usually chromosomes 7, 8, and or 13, monosomy or deletions. And these genetic mutations correlate with the overall as well as progression-free survival. As we see here, the PIG-A or B-core have got the best prognosis, whereas the DNMT3 and ASL-XL1 have got the poor prognosis, whereas no mutation are associated with the intermediate risk group. Now, PNH can be seen, subtle changes of PNH can be seen in up to 2/3 of the aplastic anemia patients at diagnosis, and they are of no significance. Clinical PNH associated with the intravascular hemolysis or thrombosis can be seen with either with no bone marrow abnormality or in association with the primary aplastic anemia or MDS. So this is the algorithm that our team proposed, and we try to follow this. And any patient presented with the aplastic anemia, if the history is typical without any family history, then it is likely to be the idiopathic aplastic anemia. Any family history of anemia, short stature, or dysmorphia points towards the MDS or inherited bone marrow failure syndromes. And on examination, if there is short stature or any dysmorphic feature, we try to rule out inherited bone marrow failure syndrome by chromosome breakage analysis or telomere length analysis or exome sequencing in selected cases like the case I mentioned. In idiopathic aplastic anemia patients, there is no dysmorphic features. Patient is perfectly normal, and usually there is nothing except for the pallor. CBC usually shows low ANC, low hemoglobin with increased MCV and moderately high MCV, as well as the relative lymphocytosis and thrombocytopenia. And peripheral blood film examination is one of the most rewarding things that we always advocate, and I personally look at the peripheral blood film. The typical findings are macrocytosis, perfectly normal morphology of the platelets as well as the neutrophils. Any abnormality in the morphology of the platelet or neutrophil points towards the dysplasia. And similarly, I've already explained the findings, typical findings in the bone marrow. Any significant dysplasia points towards either the underlying inherited bone marrow failure syndrome or MDS or underlying acute myeloid leukemia, hypoplastic AML, and we do the relevant studies to rule out these disorders. If there is absent iron, because in idiopathic aplastic anemia, the iron is increased. Absent iron in the bone marrow points towards the presence of hemolytic PNH, and we do the FLAIR or PNH studies to rule out the presence of PNH. Now, clinical course, there are patients who have got stable aplastic anemia. There can be monocytopenia, bicytopenia that continue for years. It can present, it can progress, or with the progressively worsening pancytopenias, and ultimately leads to severe aplastic anemia. And around 15 to 20% over 5 to 10 years, they can transform into PNH, MDS, or AML. Now, when and whom to treat, I'll explain subsequently how to treat these patients. Now, this is a 27-year-old female. She was recently diagnosed at a very severe aplastic anemia. He presented with 3 weeks history of continuous fever, ecchymosis all over the body, and shortness of breath. She was given short course of cyclosporin plus L-Tumubag, but that was stopped due to markedly deranged LFTs. She had haploidentical brother and was referred for BMT to our center. This is her chest X-ray. We can see a large cavity and mass in the left, middle, and upper lobe. The same finding was seen in the HRCT of the chest. If we can see the large lesion that was the that was labeled as aspergilloma. What should be the appropriate management in these patients? Now, question is whether should we proceed to transplant, being the only life-saving treatment? Is she a candidate for intensive immunosuppressive therapy, including ATG? Should we be managed with the supportive care only? So these are the different options. Now, her BL revealed multi-drug resistant Klebsiella pneumoniae. There were no, surprisingly, despite being labeled as a patient with aspergilloma, there were no fungal hyphae and no growth. Her galactomannan and beta-glucan markers were negative. She was given appropriate IV antibiotics according to the culture sensitivity. Plus, we added amphotericin and later on caspofungin because there was strong suspicion of aspergilloma. She was given irradiated granulocyte transfusions, and at the same time, we started cyclosporin plus L-Tumubag. And 2 months later, her CBC revealed ANC of 2.1. She was transfusion independent with hemoglobin of 12.3, but still had persistent bleeding and thrombocytopenia. Still, there is not complete resolution of her lung lesion, and we may require some lobectomy before taking her to transplant. Now, treatment decisions. In medically fit patients who are less than, traditionally people say less than 40 years are a candidate for transplant, but we usually keep this bracket up 45 to 50 years. Any patient who is up to 45 to 50 years and medically fit, we still go for transplant as the first option. Other than that, we go for the intensive chemotherapy that includes cyclosporin, ATG, cyclosporin plus L-Tumubag. So medically fit patients who have impaired performance status medically unfit patients with poor performance status or comorbids. Neither transplant nor intensive therapy is the option like these patients, but they can tolerate less intensive immunosuppressive therapy or eltrombopag as single agent. And we should try to improve the comorbid medical conditions to enable the treatment with most efficacious therapy rather than giving the compromised treatment. Frail patients' treatment should be individualized. They can be candidate of the supportive care or single agent eltrombopag. Now, age and ANC are the most important deciding factors. If the ANC is less, the patient has got very severe aplastic anemia, or choice or option goes in favor of transplant because immunosuppressive therapy may take 4 to 8 weeks for response to occur, and patients with very severe aplastic anemia do not survive that long in our setup. That is the reason that we have got higher threshold of aplastic anemia going for the HCT compared with the immunosuppressive therapy. And if the patient has got a higher age bracket like 45 to 50 years, then of course immunosuppressive therapy is the treatment of choice. Now, triple immunosuppressive therapy that should include the HARS-ATG, cyclosporin, and eltrombopag is the treatment of choice. And this is the typical regimen that is we prescribe. That is HARS-ATG 40 milligram per kg per day for 4 days and 6 milligram of cyclosporin. And we do not prescribe 150 milligram maximum. We usually start at 50 milligram of eltrombopag and maximum go up to 75 milligram per day. That is recommended. For frail patients, single agent or less intensive immunosuppressive therapy can be given. Approximately 2/3 of the patient they respond, but only 1/3 would achieve the complete response. The dose in children is different. If the patient are on azoles, especially voriconazole, we substantially reduce the dose of cyclosporin in children. Otherwise, pediatric patients, the dose is 5 to 7.5 milligram twice daily. For moderate aplastic anemia or non-aplastic anemia, treatment has to be individualized, observation only, or if the patient is transfusion dependent or becomes symptomatic, we can have the proceed with the low intensity immunosuppressive therapy or with single agent eltrombopag, or we can go for the supportive care only. For refractory and relapsed aplastic anemia, if transplant eligible, transplant is from alternate. We do not have the matched unrelated donor available, but we usually proceed with the haploidentical transplant. And if patient is not fit for the transplant, the option can be low intensity immunosuppressive therapy. And if it is fit, we can go for the triple IST using alternate source of ATG. But again, treatment has to be individualized. More important is what not to do in aplastic anemia. In our country, these are the things that we usually see, and we discourage and recommend that these should not be done. For example, prophylactic unnecessary transfusions of blood products, especially 1 or 2 random donor transfusions of platelets, lead to allosensitization, alloimmunization, platelet effectiveness, as well as the poor transplant outcome. corticosteroids are of unproven benefit and other than part of the immunosuppressive therapy for the serum sickness, prophylaxis should not be given. There is no role for GCSF or erythropoietin as a part of treatment, except for the short course given in transient aplasia. Unnecessary observation and delay in severe and very severe aplastic anemia because there is a short window of stability, and once patient gets some invasive fungal infection, he becomes ineligible for transplant. And giving ATG in non-severe aplastic anemia in old patients should be avoided because the patient will become susceptible to multiple infections leading to the multiple morbidities. I'll quickly review the blood component support. Patients should receive leukodepleted blood products, and preferably should these blood products, if the facilities are available, should be irradiated, especially if the patient has received ATG or following immunosuppressive therapy with alemtuzumab. Prophylactic platelet transfusions increase aluminization. A transfusion threshold should be less than 10. My personal threshold is less than 5. And any patient who has got platelet count of more than 5, I do not go for transfusion unless the patient has got neutropenic fever or patient has got bleeding. For patient who got sepsis, the threshold should be more than 20. Patients who are receiving ATG should be maintain platelet count of more than 20. And aluminization, as I've already mentioned, if the platelets are not filtered or leukodepleted. For refractory, I mean, HLA matched or HPA matched, these are not available in our country. What we do in the patient who has got the severe platelet effectiveness, we do the CDC cross match of 4 or 5 donors, and anybody who has got the best match out of the CDC 5-6 donors, we select donor who has got the least incompatibility in the CDC cross match. Other option is that the patient who is continuously bleeding or require platelet transfusions for any surgical procedure or for bleeding episode, we give small infusions over prolonged period of time, continuous platelet transfusions, single donor transfusions, maybe 20 to 25 ml per hour, continuous over 24 hours. Hemoglobin usually threshold is 7 to 8 gram per DL. And if the patient has got comorbidities, of course, cardiac or pulmonary, would require higher threshold of red cell transfusions. Now, this is something that is debatable, should be cautiously used, irradiated granulocytes, because it is associated with aluminization, leading to poor transplant outcome as well as the acute lung injury. But of course, it is one of the useful things if the patient has got mold infection or severe sepsis that has not responded to antibiotics. In patient who has got multiple transfusions and ferritin is more than 1000, should receive the iron chelation. Our preference is the defragirax. But of course, the patient who is already on cyclosporin should be cautiously given defragirax because of the impaired renal functions. Now, these are something that depends upon the individual preference and individual centers guidelines, because there are no standard guidelines on using of antifungal prophylaxis. We use in certain selected patients who are high risk of aspergillosis, and we give for 3-4 weeks. Antibacterial prophylaxis again is debatable, and depending upon the the center's preference and guidelines, we give in selected patients for 2 to 4 weeks if there is high risk of infection, but as a standard of care, we do not give. Antiviral prophylaxis, we do give following ATG and following transplant till the patient is on immunosuppressive therapy, he is on acyclovir. PCP prophylaxis, again, we offer to patients who have undergone the bone marrow transplant or immunosuppressive therapy using ATG. Otherwise, do not give. Vaccination, if the patient has got adequate T lymphocyte, then it is of useful. I mean, has got some utility. Otherwise, it may not be useful. Now, coming to the summary, aplastic anemia must be distinguished from transient cytopenias and other causes of persistent pancytopenia. Inherited bone marrow failure needs to be ruled out in all patients less than 40 years of age. In pediatric patients, up to 25% of patients may have some underlying inherited bone marrow failure syndrome and should be ruled out. For fit patients and patients who are non-HCT eligible, triple IST is the treatment of choice. For all other categories, treatment should be individualized, and we can go for the triple IST or single agent IST or single agent L2-Lupac. Supportive care is an important component in the management of aplastic anemia. And that was all from my side, and thank you for your attention.
Well, Dr. Ahmed, congratulations. You really did a great job in educating us, especially about the local perspective. You know, here in the North America, we read textbooks, we see patients, they are presenting differently, they're managed differently. So it's really educational for everybody to learn the local perspective. Now, there are some questions out there. I think one of the attendee wanted to hear a little more about pediatric or really very young children, their management. Somebody asked a question about MDS and AML. Is it commonly seen as a complication of aplastic anemia in children, and when to suspect?
In pediatric cases, treatment of choice remains bone marrow transplant, and immunosuppressive therapy is the only option in patients who are unfit for transplant or do not have got any donor. I mean, if this is the transplant option is not available, then we can go for the triple IST. Otherwise, this is not the treatment of choice. Then the inherited bone marrow failure syndrome, if they are followed up over 5 to 10 years, even up to 25% will evolve into myelodysplasia and into the PNH or AML. When to suspect? When the patient has got increase in the white cell count and it becomes transfusion independent or has got some evidence of hemolysis. If we do repeat the bone marrow and the bone marrow cellularity has increased, that is the point. Then one should suspect that the patient has transformed. And there are certain other findings in the bone marrow that will point out towards the aplasia, towards the myelodysplasia, like the abnormalities in the white cells, into the red cell precursors, and into the megakaryocytes. And then you have got the cytogenetic abnormalities of chromosome 7, 8, or 30 that are more common.
All right. There was another question. Why is a trial of GCSF and erythropoietin not indicated in aplastic anemia patients?
I've mentioned in one of our studies that the higher level of GCSF and thrombopoietin was significantly higher among aplastic anemia patients. So they are already loaded with GCSF, indigenous GCSF and thrombopoietin. So they are of not proven benefit in the management of aplastic anemia.
There's another question. Shall we do next-gen sequencing in all aplastic patients? Is there any particular age group where we recommend it more than the others?
A recommendation is any patient who has got who is less than 40 years of age and there is a strong suspicion of the underlying inherited bone marrow failure syndrome. Ideally, everyone should undergo, but if the chromosome breakage is negative and there is strong suspicion of underlying inherited bone marrow failure syndrome, we do not have got the option other than NGS. Ideally, patients should undergo.
Great. I think there's a practical question about the cost. How much is the cost of care for, I believe, conservative care without transplant for a year, or a transplant cost? And if a patient is non-affording, what are the options? And I think that's a huge question. So let's see if you can help us on that, please.
Actually, the supportive care cost and even immunospecific therapy cost exceeds the one-time cost of bone marrow transplant. That is one of the reasons that our first option remains the bone marrow transplant, and we even with the minimal comorbids and patient is up to 45 to 50 years, we go for the transplant. For patients who are non-folding, at our particular center that I am currently working in, we have got certain facilities and there are certain funds available from Pakistan PATHWEL and some donor agencies. They give some financial assistance. And secondly, we have developed a model that is based on substantially low cost transplant as well as the supportive treatment that is much less than the most of the private setups in this country.
This is great. I think this, if that model can be shared with other regional centers and other countries in the neighboring countries, because the socioeconomic challenges are shared across the board in the region. So that will be huge.
What we do is we have got MOU with the Pakistan PATHWEL. That is a government agency that supports the needy patients. They contribute approximately 40 to 50% of the total transplant cost. They gave up to 1 million financial assistance to all transplant patients. Then we have got MOU with that another NGO, that is DKMS Germany. They give financial assistance for thalassemia patients, the bone marrow transplant of thalassemia patient. They give part of the treatment, they subsidize. Then what we have done is we have negotiated special prices with the pharmaceuticals. The pharmaceuticals and medicines we provided to our center, the prices are substantially lower than the market prices. And we, I mean, the transfer or this subsidy to the patients. Instead of keeping with us, we transfer all this benefit to the patients. Then we have got our own diagnostic facilities, not all, but the routine diagnostics. We have got our own blood transfusion facilities, and we that are provided at substantially low cost. So this is the model that
Great.
is based on the self-sustaining model. It's a non-profit organization.
Wonderful. Thank you. There's another technical question regarding making decision about transplant and other modules of therapy. What percentage of PNH clone will significantly impact your decision of treatment regarding transplant or not?
I mean, the presence of PNH clone is not a contraindication for transplant. The only thing is that if there is significant clone mean around 10% or more, then we have to make certain changes into the conditioning protocol. And if this flare is done on the monocytes and neutrophil, then significance level can be even up to 1%.
Oh, wonderful. I think we have another 7-8 minutes. So I really am enjoying this interactive sessions. I'm sure our listeners are also enjoying it. There's a question about a 52-year-old female with severe aplastic anemia and has a monosomy 7. What is the best treatment modality considering this cytogenetics?
I think bone marrow transplant, allogenic bone marrow transplant should be the first option.
That's great. Thank you for that.
But depends upon her fitness. If the
performance, donor availability, and all those factors. So you're right. Yeah. There was another question, and that could be maybe a request how to, maybe refer a patient. I have a question. We have a patient, 52-year-old, non-CKD on dialysis and now developed aplastic anemia. How to approach such a patient?
Can you please repeat this question?
It's a 52-year-old patient on dialysis and then recently diagnosed with aplastic anemia. And they are asking, how should we manage this patient?
The choice of treatment, depending upon her fitness. If she has got a very severe aplastic anemia and is a candidate for transplant, then she can undergo bone marrow transplant with the facilities for the hemodialysis. And a good clinical pharmacist can guide on the frequency of the hemodialysis. And there are certain drugs that are dialysable and others are non-dialysable. If she is unfit, we can go for the single agent immunospecific therapy like the Altumopag.
A very similar question, but the age is different now. They said a patient 70-year-old with severe diabetes and kidney failure on dialysis. I believe dialysis is 2 times in a week. Now presents with severe aplastic anemia. So what we will do?
There are option is either the supportive care, the best supportive care, or you can cautiously try the Altumopag.
And there was a question about, pediatric perspective. So up to what age your center or your team accommodate patients? All because we saw the graph from Pakistan, looks like the vast majority of the patients are in the pediatric and very young age. So is there a pediatric physician who gets involved in the care if there are infants or, 1 to 2-year-old children?
We usually don't take any child who is less than 2 years of age. And we do take child with 2 years or more than 2 years of age, and we get the pediatric consultation for these patients.
Okay, great. There's another question. Could you please guide us on the treatment option for ITP in infants beyond steroids and IVIG? Especially, is the anti-D immunoglobulin safe and recommended in infants? So I think this is a question on the ITP.
ITP, we can, the first line would be the steroids instead of IVIG. That depends upon the, if it is infant. Infant? Yes,
Right,
infant.
correct.
They are asking beyond steroid and IVIG.
Correct.
And anti-D can be given. Anti-D can be given to
Sure.
the infants. Yes. But usually in chronic ITP, if the patient is asymptomatic, my option for treatment of chronic ITP would be patience. Patience is the most important thing that yields the best results. Because in my experience, the morbidity and mortality of treatment is more than the ITP.
Right. There is a question about how to distinguish between a person who present with just transient pancytopenia or ultimately have a persistent pancytopenia and aplastic anemia. So I guess their question may be like how long we follow these patients and when we declare that this is not something secondary or transient, this is probably aplastic anemia.
Our approach is to immediately proceed for the preparation of the transplant, doing the transplant workup, HLA typing. And if it is reversible, it should reverse within 4 to 8 weeks' time. And if it doesn't reverse within 4 to 8 weeks' time, the option remains the bone marrow transplant. It is unlikely to be a transient aplastic.
Yeah, there are two questions regarding diagnosis. In a pediatric patient with idiopathic aplastic anemia not affording for bone marrow transplant. So I guess they are saying that, transplant is not an option for social reasons or economic reasons. What should be done as an initial therapy?
I mean, one can try cyclosporin alone or the cyclosporin plus ATG.
Right. Okay. Well, thank you. I think last 2 minutes, there's another question about an 8-year-old boy previously labeled as an ITP with slightly raised MCV with suboptimal response to steroid and L-Trombovac. Bone marrow examination is not done in diagnosis. Should bone marrow examination be done to exclude evolving aplasia?
Yes, there is clue into it because macrocytosis is usually associated with aplasia, not
Great.
ITP.
Wonderful. So last 1 minute, Dr. Parvez, do you want to share any words of wisdom before we close the session? We have recorded this session. We will host this session on the Apna Academy website. So if you want to share any words of wisdom for the young, and I really appreciate you have trained a generation of oncologists and hematologists in Pakistan. Though there is still extreme shortage of well-trained oncologists and hematologists in Pakistan. So we need to continue to collaborate together and how to bridge the gap.
Thank you very much, Faiz, for taking me in this webinar. My message is that severe aplastic anemia is a medical emergency and should be promptly treated. Any wastage of time beyond maybe few days can lead to irreversible damage to the patient.
Wonderful. Great advice. Thank you so much. It was a real distinct pleasure to have you as one of our speaker, and we look forward to, have you come back in the future as well. Our next session is also continuation of the same theme, but we will be really focusing on, there are some questions about the transplant. And so generally in a transplant, a multidisciplinary meeting is done where the transplant decisions are made. And we'll have an outstanding speaker, Dr. Raheel, who will be speaking about transplant interventions for aplastic anemia in our next sessions. Thank you, everyone.
Thank you very much.
Bye.